Good morning, everybody, and welcome to our last South East Perinatal Mental Health webinar of the year. I can't believe that we're in December already. So I'll just start off with some housekeeping as usual before we get started. So can I just remind everybody to keep yourselves on mute and turn your videos off unless you're presenting. Obviously, please do switch them on to enter into discussion and questions. Please raise your hand if you want to ask a question, and also use the chat function. It's always great if people are happy to introduce themselves in the chat, then we know who we've got joining us today. Introduce yourself to others. And just to remind everybody, as always, we are recording this webinar, so it will be available on our website later on for those that were not able to join us in person this morning. Okay. So our focus this morning is on MBRRACE and the latest MBRRACE report that was published last month. As usual, Jenny and I will kick off with a national and regional update. Then we will follow on from a great presentation from Judy Shakespeare, who will be giving the key messages for midwives and GPs from MBRRACE. Then Andrew Cairns, who unfortunately couldn't be with us this morning, but has kindly recorded his presentation on his section on maternal suicide from the MBRRACE report. And then we are hoping at 11:05 that Dr. Adrian Whittington will be joining us. There's been lots of questions. We obviously did a slide at the webinar last month in terms of the piloting of the mental health and wellbeing practitioner roles in specialist perinatal mental health services. There's been quite a lot of queries about that. So we've asked Adrian if he could come and join us, and he'll give a bit of a presentation and hopefully answer any questions regarding that. I think the key message is to let everybody know that the deadline for expressions of interest for that have been extended to the 18th of December. Now, I say with a caveat that Adrian will be joining us because I know he's got a really busy schedule today. So we are hoping that he will be with us at 11:05, and if not, Jenny and I will do a dance or give as much information as we can on that. So we'll see how we go today. Okay, so we'll kick off with a bit of a national and regional update. And first of all, I want to do a massive thank you to Yvette, who will be leaving us in January. So this is not her last webinar. She will be with us in January, but our webinar in January is a joint webinar with the national team on provider collaboratives. And I will also not be with us for the January webinar as I will be on leave. So I wanted to take the opportunity to thank Yvette today for all her hard work. So Yvette is often hiding behind the scenes, but doing all the work to keep Jenny and I in check. She has obviously led on all the work on the Perinatal Mental Health Academy, also all the work that we did on web beds that has now moved to the new capacity management system. So she does a lot of the work behind the scenes for the webinars, and we will be very sad to lose her from our team as she goes on to pastures new at the end of January. But we just wanted to say a massive thank you for all her hard work. Yvette, I'm going to put you on the spot. I don't know if you want to switch your camera on and give a wave or not. I expect you'll be cursing me for saying that, but yeah, just a massive thank you for all your work.
Well, thank you so much. It's been an absolute pleasure working with you all, and it's been such a brilliant programme to work on. So thank you for being such a lovely team, and thank you to everyone else out there in the perinatal mental health world.
Great, thank you, Vet. I'll take the focus off you again because I know you won't like that. So we'll move on, but thank you very much. So that takes us a nice segue into mother and baby units, thinking about the work that Yvette did in terms of web beds and moving over to the capacity planning management system. So this is just to highlight, hopefully people are all aware of this, but just in case you're not, that the SLAM mother and baby unit is now shut from the 2nd of December for a 3-month period. It's due to reopen in March for refurbishment. So all their mother and baby unit beds are currently shut. And therefore, if you need to find a national bed, please obviously use the new capacity planning management system in order to find bed availability. So just to make you aware of that. Okay. Another really important plug, there is a national ethnicity data quality survey out for specialist community services at the moment. The deadline for completion is Friday the 13th of January, so there's an extended timeline, bearing in mind that we have the Christmas periods coming up. I think what's really important to consider for this is that that the recording of the ethnicity is still really, really poor, unfortunately, nationally. And we know with our important subject that we are looking at today in terms of the MBRRACE report, that actually the outcomes for women of ethnic minorities is still poorer. So it's really important that we record ethnicity, but also that that people complete this survey in order to look at what are maybe some of the barriers in terms of why it's not being recorded, or how we can support from both a regional and national perspective. So please, can I encourage people to fill out that survey, and please pass on to colleagues. Okay. So I'm not going to go through all the detail of this. You'll have it when the slides come out. But just to update you that NICE are currently looking to recruit committee members to support the clinical guideline updates within the Women's Health Suite. So they're particularly looking for colleagues within the maternity workforce, so midwives, neonatal physicians and GPs, also gynecologists and obstetric anaesthetists. There is details and links on the slides, so please do share this widely. Have a look on the website if you're interested, and yeah, it'll be a great piece of work. Okay. There is a national webinar taking place on the 18th of January in terms of improving the perinatal mental health MHSDS data quality. So the target audience is anybody submitting data to the MHSDS, can never say this, MHSDS, clinicians, service managers and commissioners, and then also regional data quality leads and ourselves at the regional team. So there is the opportunity to submit questions in advance that you want covered, and you do need to register for the webinar. But we would again strongly encourage that people sign up to that. It's a very useful information forum. It will be recorded, so if you're not able to attend on the day, it will be available on the collaboration platform following the event. Okay. There is some updated frequently asked questions from Health Education England in terms of the NHS funded EMDR training programme that's starting in 2023. So again, I won't go through the detail of that, but do have a look. And if you have any queries, then please obviously email HEE directly, and there's further information on the website as well. So just some useful support tools for you there. An update, particularly for the South East, but if you're joining elsewhere in the country, then obviously do speak to your regional teams. But within the South East, we've been allocated 8 places on the perinatal mental health postgraduate module, the phase 2, which starts in February. So we had originally been allocated 7 places in the South East, and we managed to get an extra place, so that's great. If you were successful in getting a place, you will have been informed. We are always well oversubscribed in terms of the numbers that apply and the numbers that we're able to obviously allocate places, 8 for the whole of South East. So the nominations for phase 3 will open again in April, and obviously we keep a sort of waiting list of those that have applied that can reapply again in the future. As I said, if you're joining from elsewhere in the country, not in the South East, then speak to your regional teams about your own allocations. Okay, so I feel a little bit at this point like a broken record, because we do this plug every month, But just to say, there are still places available for the cultural competency and safety workshops. The December workshops, unfortunately, had to be postponed due to trainer sickness. And so the December workshops are now taking place on Thursday, the 26th and Friday, the 27th of January. And then there's a further cohort on the 2nd and 3rd of March. So please do encourage colleagues to sign up to it. You can do that via the Perinatal Mental Health Academy. It's a fantastic opportunity of training. We do appreciate how busy services are and the pressures of releasing staff, but if you can, it's a great opportunity of training. And then also to plug the Gypsy and Traveller Cultural Awareness training. As you're aware, this is online training. It's 4 15-minute modules. They can be done at any point. Our license runs out on the 28th of February, so this is kind of your last chance to get in there and do that. It's a great piece of training. Jenny and I have both done it. And we would strongly recommend it. So as Jenny said previously, and I think I have on some of the webinars, we haven't had the uptake we would have hoped for this training, and it is a really good resource. So please can we encourage you to sign up to it. Okay, I'm going to hand over to Jenny at this point.
Good morning, everybody. So the first thing I wanted to mention today was that I'm sure you'll all be aware of the Perinatal Pathways tool. So the pilot for dads and partners was launched on the 30th of November, and it's just a plea to anybody that's on the call who wants to be part of the pilot. I'm still waiting for a couple of lead names from a couple of the services. So please, if you could get back to me before Christmas with your lead names, that would be really helpful. Thank you. Next slide, please. And seamlessly segueing into the new Partners Ambition frequently answered questions, that's now available. So the link is there on the slides. It may have come to you by another route, but I would recommend everybody to have a look at this because there's been a lot of work and consultation that's gone into getting these right, and I hope there's a lot of helpful information in there. Next slide, please. We haven't got very many resources this month, but I think this is a really important one to highlight, particularly for our maternal mental health services. So it's a miscarriage support tool to support people who've had a miscarriage and are considering their next pregnancy. And there's a lot of great resources within the tool, and that's one of Tommy's resources, and we know that we're always confident with their things. They're very high quality, and I think where they're co-produced, the language is always really good and accessible for people as well. Okay, next slide, please. And then this is not brand spanking new, which we try to bring you sort of hot off the press stuff, but we did have a really packed agenda when it was first out. So this was something which came out in OT week in November this year, and it's a really nice infographic that gives a sort of, as it says here, a snapshot of the OT role within perinatal mental health. So I'd advise everyone to look at that, and I think it, for teams where the OT role is new, it might actually give some ideas about how that role can be best utilised as well, because there's some really interesting stuff in the infographic. Okay, next slide, please. So our theme for today is the MBRRACE report, and I'm absolutely delighted to be able to introduce Judy Shakespeare, and it's so kind of you to do this for us, Judy. So Judy's been involved with MBRRACE for many years now, and she is going to talk to us about the key messages for midwives and GPs. As Liz mentioned earlier, we've got a recording of Andrew, who writes and contributes to the mental health chapter, but Judy has real oversight of MBRRACE, and I'm really, really keen for us all to hear the key messages there. So over to you, Judy, and thank you again so much.
Oh, it's an absolute pleasure, Jenny. Shall I just say next slide, please? Is that going to work?
Yeah, that's absolutely fine.
That's fine, sorry. So yes, I'm a retired GP from Oxford, and I've been involved with MBRRACE for over 20 years now, although actually I'm not going to be doing it after this year because I feel that I'm now a bit too far from the coalface, and I need to move on and do other things. I was also the RCGP perinatal mental health clinical champion for 3 years in the 2014 to 2017, and have been involved with Wessex, particularly with the Spotlight project that Carrie Ladd was involved with. So that's me. Can I have the next slide, please? This is just quick definitions so you know what maternal deaths are. These are deaths during pregnancy at any point up to 42 days postnatal. And there are direct, this is very complicated, I don't quite know why it's so complicated, direct disorder specifically related to pregnancy, and actually suicide goes in there now as well. Indirect ones where deaths result from previously existing diseases or diseases that develop during pregnancy, but are not due to direct obstetric causes. Coincidental, of course, you know, road traffic accidents, cancers, those sort of things, some of which might be related to a maternal death, particularly, say, a road traffic accident. And we do look at some of those to see whether there might be mental health problems. And then late deaths, which happen after 42 days, but before a year after the end of the pregnancy. Next, please. And the confidential inquiry into maternal deaths was introduced in 1952. I hope you don't all know this, but I think it's really very interesting, because if you look, this actually covers quite a lot of time before 1952. So in 1935, 350 women died in every 100,000 total births, which is absolutely shocking. And you'll see that that came down enormously even before the confidential inquiry started. And abortion and miscarriage, if you look at that, that of course was illegal abortion. So those were deaths from bleeding and infection. Toxemia, the language is a bit outdated here. Toxemia, the deaths were reduced by antihypertensives, hemorrhage, blood transfusion, puerperal sepsis, obviously antibiotics, and phlebitis, which is actually thromboembolic disease, reduced because women were encouraged to get up, and treatments developed for thromboembolic disease, both prophylactic and treatment doses. Next, please. The whole important thing to remember is that maternal death is really rare, but it's something that can be examined really carefully. And we know that for every maternal death, there are probably about 100 severe complications. So the messages we learn are relevant in all cases. And what we actually do is we get as much of the information together, the actual records, and go through them in detail. write reports and then come together to write the report as a multidisciplinary group. And if any of you would want to be involved in that, I'm sure that they will be delighted to take you on board. It's a really fascinating learning experience. Next, please. Just to say that most of the slides I've used, I've snaffled from the MBRRACE presentation slides from the launch. They provide all the slides online that you can use. You can't edit them, and you might see that some of these are slightly odd because the titles may not relate to what I'm actually talking about, but it's a really useful resource. And then, of course, they produce a main report, which is much more detailed, and I suggest reading or looking at that because there's a lot more information. A core report, and what I've forgotten to put in here is the most wonderful infographics, and I think the next slide might be one of them. Oh no, sorry. The areas covered in this report, which actually covers the years 218 to 220. I'm going to talk about epidemiology. I'm going to talk about a morbidity study, multimorbidity study, and particularly with diabetic ketoacidosis. In fact, I'm going to focus on multimorbidity particularly because I think you'll realise the massive interaction between physical and mental health problems. The other things that were covered in this report were cardiac disease, hypertension, and they did an interesting thing this year where they looked at the maternal deaths, but they also looked at the Health Service Investigation Bureau baby deaths, or babies who had severe brain injury when the mother had hypertensive disease. I'm not going to talk about early pregnancy loss or critical care, and I'm not going to talk about mental health and adversity specifically because Andrew's going to talk about that. Next slide, please. So these are the infographics, which I think are fantastic. So 229 women died. This is in the period during pregnancy up to 6 weeks. And this was quite a lot higher than the previous triennium. It's a rolling triennium that moves forward a year at a time. And that wasn't caused entirely by COVID, although to some extent it was. And if you look at what that means in terms of babies, 27 of their babies died, and 366 motherless children remain. So the death of one woman has really far-reaching consequences for the family. Next, please. So this is just this is the epidemiology of this period, and the hatched signs are direct deaths, and the solid lines are indirect deaths. And you'll see that psychiatric causes, the suicides are included as direct deaths, but the deaths of which are always quite a lot from substance misuse, or deaths, accidental deaths, where we're not sure really whether it's suicide, are in the indirect category. But you'll see that psychiatric deaths now equate with cardiac deaths, and look how many women died from COVID as well in this period. And if you look at the things that you might think are more important as causes of death in pregnancy, if you look down to hemorrhage or preeclampsia, it's much less than these big killers. Next slide, please. And that's shown really just in this pie chart, which demonstrates the dark blue is non-obstetric complications, and the obstetric complications are relatively small as a proportion. Next slide, please. And as we've already said, there are really big ethnic diversities, and Black women were 3.7 times more likely to die than white women, and Asian women 1.8 times. This is actually slightly less than in the last report. Sadly, the women from deprived areas die more, and that difference increases, continues to increase. And 1 in 9 of the women who died had severe and multiple disadvantage, which is why I'm going to focus on multimorbidity a lot today. Next slide, please. The late deaths, a further 289 women died after 6 weeks and before the end of the year. And most of those women died in the postnatal period, not in the antenatal period. Next slide. This is an area of particular interest to me, postnatal care, because I worry that it really is a Cinderella. Late pregnancy associated deaths, same sort of pie chart, but if you look top right, you'll see what a large proportion of those deaths are drug and alcohol misuse and suicide. And also what a lot of women die from malignancy, sadly. Next slide, please. So just to go in a bit more detail, of the women who died, 60% had pre-existing medical problems, 37 had pre-existing mental health problems, 27% were obese, and 24% were overweight. And some of these women would appear in all of those categories. Next, please. So here I'm going to talk about a case, and this was the morbidity study, and the women were found because they were diagnosed with DKA at some point. So we actually looked at the cases of 61 women. These women didn't die. That's the point. So here's a case who's a multi from an ethnic minority with chronic, poorly controlled type 1 diabetes, peripheral neuropathy, chronic pain. Those were from her diabetes, and she also had hypertension. She wasn't diagnosed until an alternative admission with D&V, and at that point, at 12 weeks. So she was diagnosed on admission. Her hemoglobin A1C was 92 millimoles per mole. And I'm not sure if that's right, sorry. That's a really, really high level. She was also on an ACE inhibitor, a statin, and pregabalin for the chronic pain. And as I'm sure you all know, all of those drugs are contraindicated in pregnancy. She had no idea about that because she'd obviously had no preconception care and nobody had seen her since she became pregnant. So a whole issue around the drugs that people shouldn't be taking in pregnancy. She was readmitted multiple times with poorly controlled hypertension and DKA. One time she tested positive for cocaine. She was delivered at 30 weeks because it was so difficult to manage her DKA and her hypertension. And at that point, her children were taken into care because quite clearly she was not managing her diabetes well. And then 8 months later, she had a termination because of her the secondary effects of her diabetes had progressed significantly, and nobody had thought about ensuring she had an effective form of contraception. She didn't die, fortunately. But let's just move on to the next slide, please. I'm not sure how I'm doing in terms of time, guys. How long have I got?
Liz,
You're
you're
fine
really
at the
better.
moment, Judy.
Sorry?
You're fine at the moment, Judy.
Okay, all right. So I just want to introduce a concept at this point that I think is really helpful. So if you've got multimorbidity, and these women have physical, as I said, and mental health problems or social problems, the difficulties don't add up. They multiply because the treatment for one condition may be contraindicated in the other condition or make the other condition worse, etc., etc. And if you're a lady like this lady, I mean, life is actually very difficult. She's likely to be someone who isn't compliant with medication, doesn't attend appointments, is often attending out of hours emergency appointments. I'm sure you all know who this lady is. And what this way of thinking about it, syndemic thinking, is that severe and multiple disadvantage promotes disease clustering. This lady had diabetes. She also had hypertension, but she also had depression or some sort of mental health problem. Nobody actually named it, and substance misuse. And what that led to, the negative health outcomes, was that she continuously got DKA. This was for me was really shocking, because although none of these ladies died, an awful lot of the babies died when their mothers got DKA. I tried to find the number and I couldn't actually find it anywhere in the report, but that's probably because I didn't look carefully enough. She also lost care of her baby, her children, her other children. I think she had 3 other children. And she had to have a TOP, and if her contraceptive needs had been addressed and she'd been willing to engage with a non-user dependent method, maybe that could have been avoided as well. So really not very good. And we'll move on to another one, if that's all right. So this woman had multiple problems. She had mental health problems, domestic violence, financial and housing problems. She had many, many appointments during pregnancy. She couldn't get a mental health appointment one time because she had a social services visit at the same time. And anyway, she couldn't afford the bus fare to the hospital, so she didn't attend several appointments. In the 3rd trimester, her blood pressure was significantly elevated with proteinuria, and she was admitted to labour ward. Her blood pressure was controlled initially with some drugs. She was given drugs for lung maturity, but she discharged herself against advice. I mean, it may be that there was nobody looking after the children, who knows? And she said she'd go and see her GP the next day, but of course she didn't. And it was a Saturday, so it was unlikely. And she was found dead a week later. So it's this multiple, one thing after another. And if we just move on to the next. So if we look at this lady, she had hypertension, she had mental health, she had domestic violence, finance, housing, childcare issues, which all made everything else worse. And her very serious negative health outcome was that she actually died, sadly, again leaving a few children without a mother or father. Next slide. So this is just a thought for us. the complexity of these women, you know, you've got diabetes, so you go and see the diabetes nurse, but you've got mental health problems, so you need to go and see the mental health nurse. You've got hypertension, so you need to go and see the blood pressure people, etc., etc. This builds up an amazing complexity, with women having many, many appointments, lots of visits being missed. And someone needs to be the key carer in this situation. That's often going to be the GP or the midwife. We haven't got this worked out yet, how to manage these people, and we need to not assume that other people are picking up the follow-up as well. I think that's really important. And we find that very often, say the diabetes women, they were being looked after very well by diabetes, the diabetes specialist nurses, but the mental health needs were being neglected. There was one lady where you know, the nurse kept talking to her about you know, the portions of what she should actually be eating, and didn't she understand that? But nobody actually asked her and discovered that she couldn't actually afford the food. You know, I mean, we have to somehow work together and be less fragmented, particularly with these ladies. Next slide, please. Okay, so I'm going to talk a little bit about cardiac deaths and hypertension. Cardiac deaths are really shockingly common in these women because they're actually very young. The important thing, I think, for you to realise that only 10% of these women had a cardiac condition recognised before pregnancy. I'm going to go through this fairly quickly. Next one, please. So one recommendation that's come out is that there were a few women who were wheezing because of pulmonary edema, not because of asthma. So this recommendation, new recommendation, is to consider wheeze which doesn't respond to standard asthma management and exertional syncope as a red flag of cardiovascular disease, in addition to orthopnea and chest pain. And I think that's really important, not to carry on plugging on treating the asthma, just think sideways. Next, please. Here's another little vignette. Two extremely obese, and what I mean by that is BMI over 40, had significant bleeding, should receive postpartum thromboprophylaxis, significant bleeding during delivery, according to RCOG guidelines. But their risk was not properly assessed, and no low molecular weight heparin was prescribed. The risk factors for ischemic heart disease overlap considerably with those associated with venous thromboembolism, and both women had clear factors for both. Both women collapsed and died from myocardial infarcts a few days after discharge from hospital. Next slide. And this is just to think that if you see a woman and she's likely to need thromboprophylaxis, think about whether she might have a cardiac diagnosis as well, because the two overlap so much. And next slide. This is just the guidelines to remind you that these are the antenatal ones on the left and the postnatal ones on the right, to remember that this is not a static process. It needs to be reviewed at various times during pregnancy and postnatally, particularly if women change weight or they're admitted to hospital. It's just to emphasise how important this is. Next, please. So now a little bit about hypertension and this combined review of the women who died from hypertension and the babies of women who had hypertension who didn't die, but the babies died or they were severely brain injured. Next, please. So this was really rather shocking that the number of women who died from pregnancy-related hypertension were increased quite a lot. And the pandemic, to some extent, affected the care of 3 of these women, but not completely. So this is really quite shocking because we thought we'd cracked hypertension. Next, please. And this one's just another vignette. I'm really just emphasising things that I think might be really important for midwives. This woman was in spontaneous labour, normal pregnancy. She was noted to have raised blood pressure when she was admitted, and it was assumed that that was caused by pain. So she went to, I don't know, a midwifery unit. Everything went fine, except that nobody ever took her blood pressure again during delivery. And she was given sintometrin for the 3rd stage of labour. An hour after birth, she had a headache, markedly elevated blood pressure, and suddenly became unresponsive, had a cerebral bleed and died the next day. And so this is just, don't forget the basics, take blood pressure and act on it and believe the results that you actually record. Next, please. This is about aspirin. So this lady had a history of PET, saw the midwife and was recommended to start her aspirin. But she didn't get it. The consultant sent a letter in the 2nd trimester and gave a letter saying that she should have aspirin, but the GP didn't get this either, and it was weeks before she actually got it, and she developed severe preeclampsia in the 3rd trimester and died. And I think this is a problem that's been getting prescriptions from GPs has been going on for a long time. Next slide. I just want to make sure that you're all aware that there is a national patient group directive saying that aspirin can be prescribed for these women by midwives and pharmacists. And I don't know whether you've got that implemented in your area, but because it requires some action to be taken, I don't know whether you're able to help on that one. Is that, or maybe we can talk about that when we come to the end. Next slide. So these were the babies that either died or were severely affected, and a racial group were there were different groups chosen, and 40 babies were looked at in all. Next slide. This is a lady who had a history of pre-existing hypertension, and she had problems initially in pregnancy. Her blood pressure was stopped when her blood pressure returned to normal in the 2nd trimester, but it became raised again at 40 weeks, and nobody worried particularly about that. And she was booked for an induction of labour, but the baby became bradycardic and she needed a caesarean section. The baby needed a lot of resuscitation and has severe brain damage as a result. Next slide. So she was discharged from obstetric care. She was downgraded, and this is in contradiction to the NICE guidelines that say that if she had a risk factor like blood pressure, she should have been offered an induction at 37 weeks. And I don't think there's any doubt that an earlier induction in this lady would have changed the outcome for the baby. And that's a life sentence for that family and for the baby. Next slide. So this is just to emphasize that we all normalise, or we might normalise blood pressure, but we need to act on it. If the reading is high, we need to do the things that we do, not find other excuses. Next slide, please. I'm going to skip that one. And just in conclusion, statistically, the maternal death rate in the UK hasn't increased, although the absolute numbers have. It's not explained by direct COVID deaths. There are still substantial inequalities in maternal mortality for Black and Asian women, and increasingly for women from deprived areas. Cardiac disorders and mental health related conditions cause equal numbers of death during and up to 6 weeks after pregnancy. Mental health related causes account for almost 40% of deaths between 6 weeks and a year after pregnancy. There's a continuing concerning rise in suicides amongst teenagers, and I'm sure Andrew will talk about that. And 1 in 9 women who die have severe and multiple disadvantage. And that's my slides. I don't know, I haven't talked about everything. I've just tried to bring to your attention the things that I think are most important for GPs and midwives. Thank you.
Oh, Judy, thank you so much. Sorry, I've got funny echo on my thing. It's a bit off-putting.
I can't hear it.
Oh, okay. I'll try and be a pro and push on through. Oh, that's better, actually. That was amazing. And
can you close the slides? Thanks.
There we are. There, we can see you properly now.
Yeah.
I find those messages so humbling, and some of them are so obvious, aren't they? I mean, the contraception has been a massive bugbear of mine throughout my career in perinatal, because so many of our mums at multiple disadvantage who are probably doing okay with 1 or 2, because those services are so hard to access sometimes, just carry on having baby after baby, and so many of our babies are unplanned. So there's a massive take home for me around contraception still.
In fact, it got slightly better during COVID, surprisingly, in that for very vulnerable women, I don't know whether this happened around your area, but in certain parts of the country, there were arrangements made so that people would have IUDs inserted before discharge from hospital. And, you know, that just seems so, why can't that happen for these women all the time?
Yeah. I remember postnatally, after I'd had mine, the contraceptive lady used to come round with, you know, so you could talk about it. And obviously most of us were thinking, well, it's okay because I'm never going to have sex again after that, so I don't need it.
It's not the right moment, really, is it?
No, but I think there are some women that's really worth sort of catching at that point, because some women are so chaotic, as we know, you just lose them, don't you, if they go. I'd love to open this up to the audience as well, because I think Judy's such an amazing resource to have. So if people have got questions, then do stick your hand up, because it's a lovely opportunity.
Can I just ask about the aspirin? It looks as though I've got a comment saying that you do provide the first box of aspirin at our trust to start them off. So it looks as though, I don't know whether that's throughout the area. I mean, that's such a small thing that required such a lot of red paper to get sorted out.
Mm. But it's those sorts of things, isn't it? It can make such a massive difference.
Mm.
And the collaborative working as well, so that we're trying to properly rationalise appointments. If you've got multiple agencies going in, I've seen that really affect women's mental health adversely. Oh, we've got a question from Kate from Dartford and Gravesome Trust. Kate,
Hello,
reveal
hi.
yourself.
Hello. Hi, I'm a perinatal mental health advanced clinical practitioner midwife from Dartford and Gravesham. Sorry, that's my dog in the background making noise. And one thing that we found really useful is that because I look after women with multiple adversities in a lower socioeconomic borough, is having that advanced level of practice means that when they come to see me, you know, I can sort out their aspirin, I can sort out UTIs, I can sort of do repeat prescriptions of blood pressure medication. And like you said, it's just one bus ride.
Yeah.
And in our trust as well, we refund their travel. And I think, you know, advanced clinical practice midwifery is going to have a massive impact, hopefully, on this at some point during the future. I just wondered your thoughts on it.
That sounds absolutely brilliant. The worry I always have is that it's sort of like the mental health side is separated from the physical side, which is so unhelpful. But it sounds like you've managed to get around that, Kate.
Yeah, so they come to see me for their mental health, and then I can sort out any other physical health. It's like a one-stop shop almost, for their midwifery appointments, their physical health problems, and we work very closely with GPs and everything, other health professionals, you know, to sort them out, so they're not having. I think we're setting them up to fail almost a lot of the time by giving them so many appointments.
It's just crazy, isn't it? And they need an advocate. They can. That makes so much difference to them.
Yeah.
And as few appointments as possible.
And even getting their travel refunded, you know, if they're on benefits, being able to go to the cashier's window and say, well, here's your bus fare back, can make a massive difference. And the other thing that we found really useful is becoming issuers of food banks. So we can give certificates now that they can take to their local food banks, because we again have had the same of women with diabetes that can't have the level of food, or you know, that they need to maintain their sugars. So issuing food bank stamps has been really useful.
That's really interesting.
Yeah. Does that go for like scratch and baby banks as well, Kate? Can you access those?
I don't think we have them in our area. We have we have one big one in each locality, because we serve 3 localities, and they can go and get food or milk or nappies or whatever they're missing at the time. They take their stamp to them and say, this is what I need.
Brilliant. Oh, and Charlotte in the chat saying that family hubs could also bring opportunities to bring care to the communities who find care hard to access. And again, it's like that one-stop shop again, isn't it? That that's what we need, is not this sort of fragmented care where the sort of narrative gets lost between professionals, but literally the team around the woman.
And we're also stretched, aren't we? We need to be working together to optimize things, because none of us can do it all ourselves. You know, it's really sad that children's centres have disappeared, so that, you know, they were such a great resource for this group of women.
Yeah, definitely. Judy, are you staying or are you leaving us? Because I was going to say, if there's any other questions, maybe you would answer them in the chat box if you're around.
Oh, I can. How much longer have you got? I can stay. That's fine.
Brilliant. Well, we'll move on to Andrew's film. And then if there's any other questions for Judy, please pop them in the chat. Okay. So I'm delighted to introduce Andrew, who some of you that have been on previous webinars will remember he did come to talk to us about the previous MBRRACE report. And he had a stinky cold, I remember. So I was very grateful that he turned up like a trooper and still presented for us. He couldn't be here today because he's also a consultant perinatal psychiatrist, and it's his ward round today. But he very kindly has recorded his talk for us, and he is one of the chapter contributors for MBRRACE. So we always get slightly nervous, as some of you that have been on this journey with us for a while will know, that when we have a film, it's a slightly nerve-wracking moment because we've had shockers with films in the past. But I'm going to hand back to Liz because I think we're there now. So
I think we're good to go. Let me know if there's any problems with sound for those that are listening.
So here we have Andrew, and he's going to be talking about his chapter.
Hello, everybody. My name is Andrew Cairns. I'm a consultant perinatal psychiatrist, but I'm also the lead psychiatric reviewer for MBRRACE. You're probably aware that we last reported on mental health deaths in the 2021 report. But looking at the data coming through from the deaths in 2020, we had a number of concerns and wanted to make you aware of these. And so I've written a chapter for this current report. You may remember that in the 2021 report, we mentioned some potential concerns about an increased rate of teenage maternal suicides, and also concern around the capacity of specialist perinatal mental health teams to see all women who needed secondary care mental health support, and to not include women who might have diagnoses such as personality disorder. In terms of the substance misuse deaths, we had some concerns around a number of cases where women were either prescribed or taking illicit pregabalin or gabapentin. And overarching, the majority of the cases was a pattern of trauma and multiple adversity, which you'll be familiar with from the past couple of reports. Again, you'll be familiar that when we look at the women who've died between 6 weeks and 1 year postpartum, the late deaths, the leading cause for a number of years now has been mental health causes. Of concern is that this proportion does seem to be gradually increasing between each triennial period. So when we look back to the 2018 report, which looked at women who died between 2014 and 16, the total proportion of suicides and substance misuse related deaths was around 31%. This increased to 34% in the 21 report. And looking at those women who died during 2020 alone, that proportion is around 38%. The difference from last year's report being an increase in the proportion of substance misuse deaths. The key concerns we had looking at the 2020 data were a significant increase in the number of women dying during pregnancy and up to 6 weeks postpartum. From the years 2017 to 19, we had 10 women dying during that triennial period, but a further 10 women died through suicide during 2020 alone during this period. And that is a statistically significant increase, relative risk of around 3 times. We also saw a further continuation of the trend that we reported on in the 21 report in increasing teenage suicides, and I'll explain a bit more about that in a moment. Looking at all of the young mothers who died in their teenage years, they all had a very similar pattern of their children being taken into care, their own complex problems around mental health, substance misuse, and domestic abuse, fitting very much with that pattern of multiple adversity which has previously been described. When we look at associations with domestic violence, then there was roughly a doubling of domestic abuse rates, both in those women dying through suicide and through substance misuse when compared to the previous 3 years of 2017 to 19. Just touching on the characteristics of the women who died, there were 28 women who died through suicide during 2020 and 27 who died through substance misuse related causes. And that compares to 62 and 58 deaths in the preceding 3 years. When we look at domestic abuse, the increase was from 18% of suicides to 32% of suicides in 2020, and from 31% to 70% of substance misuse related deaths during 2020. And elsewhere, there has been evidence published showing that there has been an increased rate of domestic violence and domestic abuse during the COVID pandemic. When we think about recommended levels of antenatal care, the rates were very similar in those women who died through suicide, but there was a large change in those women who died through substance misuse, where in the preceding 3 years, 26% of the women had access to recommended antenatal care, but that was down to 12% during 2020. And one could hypothesize that that may be related to the changes in maternity services that occurred during the beginning of the pandemic. I mentioned at the start concern about an increasing trend around teenage suicides. Thankfully, the absolute numbers are relatively small, but we've seen a shift from the 2018 report and preceding reports where the level was relatively static. In the 2018 report, we found a rate of 2.5 per 100,000 maternities. In last year's report, we reported an increased rate of around 11 per 100,000 maternities, and that represented 7 teenage mums who died during that 3-year period. And during 2020 alone, there were a further 5 suicides, and that gives a rate of 27 per 100,000 maternities. And this is a statistically significant increase, so a relative risk compared to the 2014-16 data of about 11 times. When we think about the mode of death, a mode of suicide, this has remained relatively static over many years now. Hanging remains the leading cause of maternal suicide at around half of the cases during 2020. In the last report, we'd seen deaths through overdose increasing in proportion, and that remains the case in 2020. So that was the second most common cause of maternal suicide, followed by other forms of violent death, jumping from heights, jumping in front of trains or into traffic, taking up the majority of the remaining deaths. In previous reports, when we've looked at the timing of maternal suicides, what we've typically seen is a much increased rate of deaths occurring in the postpartum year. In earlier reports, that tended to drop off towards the end of the first postpartum year. In more recent reports, and particularly in the 2021 report, we saw a very consistent level of suicide throughout the year, but lower levels during pregnancy. And as I mentioned at the start of this presentation, we saw an increased rate of suicides during pregnancy and up to 6 weeks postpartum. And so when we look at this graph of timing, we see now that shift, particularly with those early deaths becoming more common and a more of a spread throughout pregnancy and postpartum period. So if we move on just to briefly think about a couple of cases. Thinking about the teenage deaths, we had a case of a multiparous teenager who'd had a miscarriage shortly before her death. She herself had a history of child abuse and previous involvement with child and adolescent mental health services. She also had a history of substance misuse and domestic violence. A diagnosis of bipolar affective disorder had been raised, but our assessors considered that this was unlikely. She'd been referred to the perinatal mental health team, but they declined this prior to her death by suicide. And this case raises a couple of issues that I've already referred to. One is this pattern of multiple adversity, which is becoming an increasing feature of many of the women who are dying through suicide and substance misuse. And the second is the importance of specialist perinatal teams having the ability to become involved with all women who have complex mental health problems in the perinatal period. So in terms of recommendations, it's important that we recognise trauma history in our assessment of risk. and involve specialist perinatal mental health teams where there's either a history of significant involvement with secondary mental health services, and that could include child and adolescent mental health services as well as adult services, or where there is significant risk, either past or current. And particularly where this is a first pregnancy and we do not have the benefit of prior pregnancies to help us understand how this woman will adjust in terms of her mental health to becoming a parent. We also recommend that access services such as psychiatric liaison teams, crisis teams, and street triage teams should alert the specialist perinatal mental health teams to any referrals of self-harm that they receive, to allow the specialist teams to triage the cases for the need for ongoing follow-up. And finally, it's important that commissioning bodies should ensure that providers of specialist mental health teams have sufficient resource both to advise and in those complex and high-risk cases become directly involved, particularly in initial assessments when they occur in working hours. Just briefly thinking about a further case, we had a case of a non-English speaking woman who contacted her health visitor 3 months postpartum, concerned about her baby. She herself had not slept for over a week, and it was clear from the notes that this was quite a severe insomnia. She was directed to the emergency department where a psychiatric liaison team were unable to identify any low mood using a telephone interpreter. She was not referred on to a specialist perinatal mental health team, but she was commenced on an antidepressant, although she did not continue it as she was breastfeeding. A week later, her health visitor did refer to the specialist perinatal mental health team. She was called by a member of that team within the week after referral, and they offered a talking therapy, which she declined. She was referred again to the specialist team, who suggested that she should attend the emergency department, but they themselves didn't attempt to coordinate any form of urgent assessment, and she died by jumping from a height 3 days later. And our concern in this case was particularly around the ability of teams to offer direct assessments, face-to-face assessments, particularly where multiple referrals were being made with concern about mental state. And also the very severe insomnia that this particular woman and other cases that we saw was suffering, that wasn't particularly responsive to treatments that were being offered, which did include sleeping medication. Our recommendations here were of the importance to assess directly women with persistent and severe insomnia, carefully looking for signs of underlying mental illness. Importance of being alert to factors such as cultural stigma, fear of child removal, which may influence the willingness of women or their families to disclose symptoms of mental illness, thoughts of self-harm or substance misuse. And also, when we were looking at the records, clearly many teams now have moved over to electronic records systems. And we were concerned about the opportunity that professionals had to make written descriptions of the patients that they were seeing, as opposed to using tick box approaches. And so we made a recommendation that it's important that there is sufficient opportunity within electronic record systems for free text comments, rather than relying solely on tick boxes. And where a woman has a history of mental health difficulties, then we would expect all professionals to be able to make a brief comment on mental state, mental health, much as they would do for physical health. So this is not a recommendation, for example, that people should be doing an in-depth mental health assessment, but at least commenting on presentation and mood and that sort of thing. So finally, just touching on some of the findings and recommendations, you will have heard around the current report that we continue to see an increased rate of women who live in deprived areas who are dying. The majority of deaths obviously are occurring within the postpartum year. When we think about multiple adversity, we're now seeing 1 in 9 women who die who have severe and multiple disadvantage. And as I've mentioned in this talk, we've seen a significant increase during 2020 in those women dying during pregnancy and up to 6 weeks postpartum. Thank you.
Wow, very, very humbling. I think there's so many messages there for all of us working in the field. And what I would suggest, as you'll know, that the presentations come out to you recorded, and I would very strongly recommend that you include our amazing MBRRACE speakers, Judy and Andrew, within your new starter induction, whatever service you're representing today. So be that specialist perinatal, mental health services, health visiting, midwifery, anybody involved in this area. I think those two presentations are absolutely top class and should be disseminated as widely as we possibly can. So thank you again to Judy, and in absentia, thank you to Andrew as well. We're going to have a change of tone, I guess, because I know MBRRACE is always quite hard listening. So our last speaker is Adrian Whittington from HEE. And thank you so much for joining us today, Adrian.
Thank you.
And we thought it was important to have Adrian along because we have this very new and exciting role that's being offered to perinatal mental health teams, but we have had a lot of questions about it. So we thought, let's get it from the horse's mouth. So here we are with Adrian. And Judy's still on the call, so if you still have any MBRRACE related questions, do pop them in the chat, but I will hand you over to Adrian, and maybe Judy, if you pop your camera off at this point, that would be helpful, and we'll hand over to Adrian. Thank you very much.
Thanks very much, Jenny, and thanks for inviting me. Really happy to be here to be presenting on mental health and wellbeing practitioners, and to hopefully answer any questions or hear from you what the thinking is for perinatal mental health services about how and where this role might fit. So I'm Adrian Whittington. I'm National Clinical Lead for Psychological Professions, and so that means psychologists, psychological therapists and psychological practitioners, and I work across NHS England and Health Education England. So I'm not quite sure where everyone will be starting with understanding of this role, so I thought I'd just present a few slides, give a really sort of high-level overview, and then we could take any questions and comments that people want to make. So let me pick that off and share my screen. Hopefully you can see that. So mental health and wellbeing practitioner. This is a role that was developed over the past sort of 18 months or so to support community mental health transformation, so adult community mental health expansion, and to provide specific sort of additional role for that in relation to severe and complex mental health difficulties. Two kind of workforce needs that it responds to: needing to provide trauma-informed care with wider access to psychologically informed interventions, and secondly, to increase access to NICE guided psychological therapies. And I do want to be clear that these practitioners don't deliver NICE guided psychological therapies. So how are they helping us to increase access to NICE guided psychological therapies? Because they're taking up aspects of the care task that allow others to be released to train to deliver NICE guided psychological therapies, and they're also becoming potential future psychological therapists in a couple of years post qualification, when they would become eligible themselves to train as psychological therapists. So about creating future pipeline as well as releasing current suitably qualified individuals to train in psychological therapies. So they're part of this push on psychological therapies, and they have a specific focus on severe and complex mental health. Now, I don't want anyone to become more bamboozled than they are already by the array of new roles in mental health, but I thought it is worth mentioning that this role fits in the context of a bunch of other new roles that have also kind of been deployed over recent years. So we have clinical associates in psychology. Associate psychological practitioners is more in just the northwest, so it doesn't really apply here. We've had graduate mental health practitioners in the southeast, though, and you'll see, I think, that this mental health and wellbeing practitioner role is distinct from these, and serves a slightly different need to each of those. And then we also have, obviously, psychological wellbeing practitioners in IAP services and a couple of children's new roles as well that offer psychologically informed approaches. And whilst a lot of these roles have common elements, the mental health and wellbeing practitioner is unique and different in that it specifically targets those sort of severe and complex mental health difficulties. So in designing it, we set out to sort of I suppose, answer a number of tests for ourselves as to, is there really a need for a new role? And if so, what does it need to look like? And these were the tests that we set. So does it meet a specific workforce need? Well, yes, that's the one that I set out at the beginning of this presentation. Is it something that could be deployed in synergy with, but is distinct from established roles? Yes, we think so. There's a ready supply of people who want to work in a psychologically informed role, and currently don't find a way in through other established roles into delivering health and care. Is there a national competence framework? Yes, we developed one. Is there a national curriculum? Yes, we've developed one with input from experts in the field of psychologically informed interventions. Good governance around the role, so to ensure the right supervision, particularly, and that people operate within the scope of practice that they're trained to. Doesn't disrupt other existing roles. We don't think so, and is a good return on investment. So those are the tests we set. We think we've ended up in a good place. This is the essence of the role. So it's a parallel role to psychological wellbeing practitioners, children's wellbeing practitioners, education mental practitioners, mental health practitioners, but with a specific focus on adults with more complex mental health problems. It aligns to principles of trauma-informed care. And they're essentially doing two things. They're already being deployed in adult community services, and they're doing two things there. So one is they're developing personalised care plans with people so that people can make best use of resources available within the team and beyond the team in the community. And secondly, they're delivering some specific wellbeing focused, excuse me, psychologically informed interventions. And some of these are recommended by NICE guidance, others are sort of empirically supported, but not in NICE guidance at this point, but intended to be evidence-based interventions according to best available evidence. These are the interventions that they learn. So they're quite specific. We can be very clear what they are and aren't trained to deliver. They deliver behavioural activation and graded exposure for people with more severe mental health problems. They teach problem-solving skills. They have an intervention, an evidence-based intervention that supports improving sleep. They help people with difficult to manage emotions and how to recognise and manage those. They have a specific intervention in guided self-help for non-underweight eating disorders. And they have, again, an intervention for building confidence and for supporting people with basic information about medication. So those are the key elements of the role. The training consists of a one-year programme. Can either be delivered at a level 6, which is a graduate certificate, or a level 7, which is a postgraduate certificate. And it's very competence-based, so they're learning through skills development, workshop-type content. They're assessed on their delivery of the sort of practical components through observation, and they have sort of clinical skills development and supervision in practice as well in the clinical setting. And so we think the role sort of has these key elements that support with workforce challenges. First is they deliver that sort of care coordination function and risk management in situations where there is significant team pressure. They're an extra member of the team within the MDT. They deliver those wellbeing focused psychologically informed interventions that I've outlined. They create that capacity for more experienced staff to train as therapists, and they themselves become a future potential supply pool to train as therapists to expand that access to psychological therapies. And in terms of commissioning in the South East, we have courses delivered by Oxford Health and Sussex University. We believe there's capacity in the South East for additional trainees in the coming year. And we're now opening this opportunity to take up places to take on these trainees to specialist perinatal mental health services, because we think it's quite a good fit in that they are trained to work with adults. They're trained to work with adults with more severe mental health problems. And we know there are some sort of significant issues with releasing staff to undertake the sort of more in-depth psychological therapies trainings, and so we think this can offer part of a solution to that. So here to just sort of hear any questions, try and respond to those if I can, about how you think this might fit or not in perinatal mental health. We have recently opened up the role also into drug and alcohol services and had an extremely sort of positive take up. I think there's going to be 70 of these practitioners in drug and alcohol services next year. So we're interested in whether this can help support perinatal mental health services too. So I'll stop there and open to any comments or questions people might want to make.
Thank you, Adrian. That was really, really helpful presentation, and I'm sure that my national clinical lead colleagues will be pinching it off us once the recording's out to share and to help understand as well. So yeah, looking to the members of the webinar audience to see if there's any specific questions for Adrian on this new role that looks really exciting. They've all gone quiet on me, Adrian.
While we're waiting for people to come in, Jenny, I mean, one thing I would add is obviously this role wasn't developed specifically for perinatal contexts. So we are now looking to commission a kind of perinatal frame of mind overlay component that would sit alongside it to ensure that people really get that. But so much of the learning is in the practice setting that we think that's where some of the sort of adaptations and specifics of perinatal frame of mind would come in.
Yeah, lovely. And we've got oh, Liz has answered Michelle's question in the chat about the revised deadline for submitting expression of interest, and I'll just say for everybody it's the 18th. And then there's a hand up. I'm just trying to see who that is. Alison, do you want to ask your question?
Thank you, Jenny. Yeah, hi Adrian, thanks for coming along. I'm just conscious that a lot of the funding from Higher Education England often goes to pre-existing organisations, and that specialist midwives and health visitors often sit within maternity and community services. I'm wondering if there's any sort of ability for specialist midwives and health visitors to access some of this training and these exciting roles coming forward.
Yeah, so I think the scope at the moment of the opportunity is the specialist perinatal mental health teams. If you're talking outside of that, then perhaps we need to pick that up offline to just understand exactly what you're describing there. It would be teams where they're delivering NHS commissioned healthcare, which I think everything you're describing would be in scope of that. But yeah, if there's a more specific sort of query about a service setting, then do drop me a message and we'll pick that up from the team.
Will do, thank you.
I'll put my email in the chat. And
we've got two questions in the chat. I'll take Ruth first because you've just popped up first in my chat box, who's asking, is this a paid role?
Oh, sorry, yes, that was a very obvious thing I didn't say. So there's so the education funding is fully covered by HE, and there's salary support at band 4 for the training year. In order to take one of them on, the service needs to commit to then providing a permanent position for them at band 5 on qualification.
And so I think that half answers Diane's question, which is in the chat. So Diane's asking, can you clarify what qualifications you need for the role and what banding they'll be on?
Yeah, so they can come in either with a degree in any subject for the level 7 version of the training for the postgraduate certificate, and they can come in with the equivalent of a foundation degree or other evidence of level 5 academic work for the level 6 version of the training. We have said that they don't require specific mental health experience, although it's a desirable. Obviously, it would add to people's sort of ability to come into the role and hit the ground running. But yeah, essentially, it's sort of people with an interest in mental health who've got one of that sort of academic background and can demonstrate the required personal qualities.
Emily's asking how to submit an expression of interest. Liz, do you want to take that one? Or
yeah, shall I come in here? So we have sent out to service leads for each of the perinatal mental health services within South East. So obviously for Emily, you're within South East, but if you're watching elsewhere in the country, then obviously go to your regional colleagues, asking them to submit. Obviously, we've since updated. So Michael from our South East HEE regional team has since updated with the extension. So if people can come back, there's like a little spreadsheet just to fill out with the details. So if these can come back into us, obviously the 18th is Sunday. So if we can have them by first thing Monday morning, then we can get them sent off to the national team.
If I might just mention supervision, this is one of the sort of features that in order to have good governance of the roles, which will potentially be people with very limited experience coming into quite sort of complex work. So the supervision in practice is a really key component of making it safe and effective. And at this point, the supervision requirement is that they need to have clinical skills supervision, which can be delivered in a group. It doesn't need to be individual, but that needs to come from either a clinical psychologist or a BABCP accredited CBT therapist. We are looking at widening that for the next cohort, but that's the position at the moment. And then they also have case management supervision, which can be from any qualified member of the team.
And can I just ask a very quick one? Is what's the split between the amount of time they'll be at uni and the amount of time they'll be with services?
The courses are slightly different in this, but effectively it adds up to something like a day a week in uni and the rest of the time in the service.
Oh, okay.
Some of the time in the service, they have to be doing sort of practice-based learning tasks that develop their portfolio. And they will obviously need to be doing the clinical work that they're then also putting into their portfolio in that time.
Yeah, lovely. Thank you. Brilliant. I hope that's clarified it for people, and I'll hand back to Liz now.
Thank you so much, Adrian, because I know how busy your schedule is. So we really appreciate you taking time out of your busy schedule to fly and do this. And then I know you've got something else to go to. So thank you very much.
That's great. Thanks for having me. Take care.
Cheers.
Thanks,
Bye-bye.
Adrian. Bye-bye.
Right, I will just share the last couple of slides. Just transferring over. Here we go. So if there are any other queries with regards to the roles, please obviously put them in the chat or speak to your service leads, and they can get in touch with either myself, Jenny, or Michael from our regional HEE team. I just wanted to remind everybody that the next webinar is on Wednesday, the 25th of January. That's being it's run in conjunction with the National Provider Collaborative team and will be specifically focused on perinatal mental health provider collaboratives as we start to look at them and roll them out next year. And then the last 2 dates for the financial year next year are Wednesday, the 22nd of Feb and Wednesday, the 29th of March. I know I saw earlier in the chat that there was a couple of people who were saying, can they be added to the distribution list? If you email the England MHLDA South East email address, we will get you added to the distribution list. And last but not least, we just wanted to take the opportunity to wish everybody a very, very Merry Christmas. As those of you who are regulars know, we never miss an opportunity to share a Charlie Mackesay picture, and it's been a while since we last did actually. So, you know, we appreciate how tough it remains out in services, and we've probably got a very hard winter ahead. So thank you all. Please take that back to your services as well. And have a Merry Christmas, however you may spend it. And we look forward to seeing you again in the new year. Take care of yourselves. Bye-bye.